Hey guys, welcome to our lecture. I'm Dr. Datta. I'm one of the clinical forensic medicine fellowship directors. And this is Dr. Agenor. She's a medical director of Brooklyn SART. Can you guys hear me? Perfect. So we're going to talk about non-fatal strangulation. So the point of this lecture, we want to talk about the definition of it, the complications that patients deal with, workup, and some physical exam findings as well. We're going to start with playing a video. Oh, or an audio rather. There we go.
Hello, yeah, Michelle, this is Lynn at San Diego Police Department. Is it your husband or boyfriend? It's your husband? Okay. Does he have any weapons at all? What did he do to you? Okay, I want you to try to take a deep breath and calm down. He did what? I break my neck and he's suffocating me. Okay, do you need a paramedic? Okay, Michelle, do you need a paramedic? Are you sure? Okay, he's inside your house though, right? He's not there with you? He might be taken off in the car right now. Okay, what kind of car would it be? Okay, Michelle, I want you to take a deep breath and try to calm down, okay? He's not right there, so he's... Okay, Michelle? Yeah, okay. I'm not crying. Okay. All right, do you want a paramedic? Are you sure if you can't breathe? How come I can't breathe? How come I can't? All right, let me talk to the lady that was there again, okay?
So anything concerning on the audio that you guys just heard? The paramedic asked her, do you think you need medical attention? She said, no, I don't think so. So what do you guys think? I see some people nodding yes. Okay, what's your biggest concern so far? Yeah. Yeah, concern for possible airway compromise, right? You can see she's short of breath. She's saying she can't breathe in the context of saying she was choked by her partner. A lot of patients, when this happens to them, they never really seek medical attention because their goal is to get physically safe from their perps or their abusers. So what they do is they would call 911, and in their mind, their most important thing is to be physically safe. So their goal is to have NYPD law enforcement with them, and they're not really thinking about their physical complaints right now because they're running on adrenaline and they're terrified. So it's important for us to know what exactly the long-term complications of strangulation is. And strangulation is essentially a compression externally that causes closures of the vasculature and the vessels in the neck. A lot of patients will use the word choking or suffocation, and it's important to distinguish the difference because choking is a form of suffocation. It fills within the categories of asphyxia, but the difference is that choking is due to an obstruction within the airway passage versus strangulation is some external pressure that's causing blockage of the passages in the airway. Essentially choking, there's different forms of choking. People can eat a piece of fruit and choke on something. You can suffocate someone, you can smother someone. So it's important to know those difference. There's three main forms of strangulation. There's ligature, manual, and hanging. In this lecture, we'll be talking about manual strangulation. So the important thing to know about manual strangulation is if someone knows the anatomy or the vasculature of the neck quite well, they can actually kill somebody with one hand and leave little to no marks. The reason being is because, and we'll talk about it, is it doesn't take too much pressure to have access to these vessels and to cause significant injury. A reason why a lot of people do strangulations, it's a way to show control. Like they have control over the person's life. They can end their life whenever they feel like doing it. It's a way to terrorize and instill fear in these patients. There's two typical forms of strangulation that people can also do is bar hold versus the carotid sleeper hold. Bar hold is when you obstruct the trachea, the airway itself, versus carotid sleeper, you're occluding the carotid arteries, the jugular vein, which can then stimulate the carotid sinuses, which then leads to someone losing consciousness. I don't know if you guys saw that video that was circulating of that homeless young man that was strangled in the train. That was a form, he did the bar hold on him, and that was a form of strangulation. So at that instance, he was blocking his airway and his vessels, and everyone was seeing that. And we'll talk about some physical exam findings you'll see when someone loses oxygenation in the brain. So there's two types of brain injuries. You have hypoxic and anoxic brain injury. Hypoxic is when someone gets blood flow and oxygenation to the brain, but it's not as much as it requires, versus anoxic brain injuries, there's completely loss of oxygenation to the brain. And you typically see that type of injuries with strangulation. So there's fatal versus non-fatal strangulation. Fatal strangulation, it tends to occur, like we said, with no external signs of any injury. The best way to document a strangulation case for something that's fatal is through an autopsy by an experienced medical examiner. And we'll show you some examples of an autopsy of a fatal strangulation. So non-fatal strangulation, this is where we come in. Our goal as EM providers is to, one, notice if the patient was strangled, because a lot of times they'll say they weren't, they'll just say they browned out, they don't really recall things. Those are some high-risk symptoms or concerning parts of the story that makes you think this patient was possibly strangled. And this is important because it's going to help us with documentation. Like we said, 50% of patients have visible injuries. So if there's no external visible injuries, and if this patient wants to go and press charges on this perpetrator, we have to have documentation that supports their story. Couple of things, never write alleged on what if you use a patient's words directly, don't say alleged. And another thing is, if you don't see an external signs of injury, you could say patient said immediately, I couldn't breathe, or patient said that they were blacking out, or they saw a dim light. Those are all things that's concerning of strangulation and decrease blood flow to the brain. So some facts about strangulation. It's extremely common. It happens mostly in domestic violence cases. It tends to happen later in the relationship, and it tends to affect mostly women, and men are normally the perps of the case. I'm talking about the Sammy case.
Yes, I can mention a case that I saw with the MD's office, which was a case where an individual came in after, like, they were obviously deceased at that point. In reviewing the police report that they had filed prior to their death, there are multiple cases of strangulation that happened. The individual had went to jail for a certain period of time, was released. He actually went into her home, fractured her arm, and strangled her to death. And then afterwards, barricaded himself within the home, called his mother, told his mother that he killed her. At that time, when police arrived on the scene, he threatened to shoot the police officers that were there. And then later on, when we were doing the autopsy, the MEs was mostly focusing on the fracture. They thought that she possibly may have died just from the fracture from blood loss. However, when it comes to doing autopsies, one thing that we notice when the death actually occurs, like, bleeding tends to stop. But after doing further dissecting the patient or the deceased at that time, we saw signs of strangulation, which is soft tissue injury that wasn't visible on the skin at the time. But when we dissected, there was a lot of hemorrhaging around the neck and also behind the ears. And we're going to show you some pictures later on of some non-fatal strangulation where you see that typical bleeding behind the ears that you might think might be a battle sign, but it's not. And the ME I was working with at the time, they were looking for possible like a basilar fracture and things like that, but they did not find it because it was all from the hematoma and the swelling from the torn muscles in the neck.
Another thing that I want to mention again is these people, they strangled with not the intention to kill initially. It's the intentional to instill fear and essentially let their victims know, I can kill you whenever I feel like it. So it's important to note that when patients are saying they browned out or they feel safe at home or they're thinking about going back, just tell them the risks of them going back, which we'll talk about. And the studies have shown that there's a higher risk of these patients eventually dying from homicide, which is what happened with Keith's case. In addition, it tends to happen in front of children as well. And like we said, people rarely seek medical attention because they're mostly concerned about being physically safe, and they don't necessarily think something's wrong with them when it comes to their airway, their vessels in the neck. So in 2008, there was a study that showed that victims of strangulation are about 7.5 times more likely to die from homicide from the same perpetrator. It's now increased to about 8 times more likely for people to die from their perps. So what's the problem? We know that this is an engendered crime. It has serious complications. And these patients do survive. So why is it so hard for us to get justice for these patients? Several things. The most common reason is because it's not visible, there's no external injuries, and also there's not much education when it comes to the signs and symptoms of non-fatal strangulation. So we're going to talk about just some essential neck structures. You have your muscles that cover the important vessels on the neck, and then you have your artery that brings blood from the heart to the brain, and then you also have your vein that drains the blood from the brain to the heart. When someone causes an occlusion, right, if they will tend to typically drop the jugular vein first. If they occlude it, you're going to have flow going to the brain, but you're not going to have the exit of blood from the brain. So as a result, it's going to cause the blood vessels to grow larger, larger, and larger, and then it'll pop and it'll form something called petechiae. Petechiae is quite important to know because some patients can have petechiae just from bearing down, sneezing. It's quite common for some people to have it. However, if you get the history from the patient, if the patient is saying, I was in an argument with my partner and all of a sudden, he strangled me or he choked me and I saw darkness and you see petechiae around the eyes or the neck, it's concerning for non-fatal strangulation. I had a case in May where it was a toddler that was found drowned in a tub. When we were running the case, he unfortunately expired, but when we were doing our code on him, I saw some petechiae around his eyelids, on his inner mouth, and I saw some petechiae around his neck. It was very, very concerning for non-accidental trauma, particularly a strangulation injury. I worked with the ME that actually did this case, and he did in fact have findings in the autopsy of fatal strangulation. So it's important to know that you do a full physical exam, make sure you're not missing any petechiae. It's important to know with people with darker skin, like our patient population, it might be harder for us to find because petechiae is flat. It's not going to be raised. You're not going to feel any bumps. So it's important to do a very, very thorough exam. If you don't see petechiae, that does not mean the patient wasn't strangled. You can still have strangulation without any petechiae being visible. So we're going to talk about the amount of pressure that's needed to occlude these vessels. So the average handshake is about 80 to 100 pounds of pressure. To occlude the jugular vein, it's about 4 pounds of pressure. The carotid artery, it's about 11 pounds. And then you also have the tracheal, it's about 33 pounds of pressure. So as you can see, it does not require a lot of force to cause significant damage. And that is one of the reasons why if someone knows the anatomy quite well, they can cause fatal complications without any form of any external visible injuries. Another thing is we typically see when patients come in strangled, they are a bit confused and they're saying, I don't really know what happened, or I remember I was in the bedroom and then I woke up in the bathroom. They're not trying to be difficult. It's because there's no oxygenation to the brain. And when there's no oxygenation to the brain, it affects the memory. And the hippocampus is one of the first things that's affected. So they have gaps in memory. So they may remember a couple of things, but it's not going to be linear. Another thing that's important to know is sometimes these patients, they are under arrest because they're perp my tail NYPD. They're the aggressor, and I was just defending myself. So sometimes they'll come to the hospital under arrest, and it's important to essentially. And sometimes the NYPD will tell you like, oh, the patient was aggressive. They were combative. They might be intox. They may not necessarily be intoxicated. They may just have signs of significant brain injury, and that's why they're seen confused or aggressive. So this difference between consciousness and unconsciousness and death is a matter of seconds. So in the 1940s, there was this really questionable study that was done in prisoners that basically mimicked strangulation on these prisoners. And they put this device around them and they wanted to see how long it'll take for them to lose consciousness, have urinary bladder incontinence, and essentially have seizures as well. What they saw, the average of 7 seconds is when someone loses consciousness. 14 seconds, they have an anoxic seizure, 15 seconds, loss of bladder control, 30, loss of bowel control, and 1 to 2 minutes is death. This is of continuous pressure. It's important to know because we're going to show you guys a video of this man that's giving consent for his friend to strangle him.
His first getting choked out right here.
Ready?
Yes.
It's going on one split. Come on, straight up.
One split.
I haven't wanted to see this for a while.
And he goes to sleep. Pittsford, you're gonna die. And he's asleep right there.
Oh, hey.
Oh, he's being serious.
Now. Come on. Buddy.
He's very So now imagine if someone is scared for their life and they're trying to. So how does strangulation cause brain injury? So like we said, when there is no oxygenation to the brain, it kills about 32,000 neurons and about 230 million synapses, which is irreversible damage. So these patients do have gaps in memory. And there's also long-term complications. We have spoken to survivors of non-fatal strangulation, and they say, I forget things a lot, or I have memory loss, and they didn't understand it was a correlation because of this anoxic brain injury. So it's important as well, when you have these victims that come to the ERs, to make sure they have appropriate follow-up because of these long-term complications that they can experience. Like we said, they can have this behavioral changes. Most acutely is they become a bit aggressive, hostile, violent. I like to compare it to a patient that has a seizure, right? When they're post-ictal, they are confused. We're not saying they're aggressive, they're just post-ictal. These patients do have seizures, right? Or they have complete loss of consciousness where they're confused, and right before they lose consciousness, they're terrified for their lives. So it makes sense for them to be on fight or flight mode to try to protect themselves.
When looking at a particular case with George Floyd, a lot of people ask, well, you just said, okay, it takes about a minute before somebody is being strangled, and usually they die after a minute. But George Floyd, is he superhuman? He died at 8 minutes, 46 seconds. Well, as Dr. Datta mentioned before, the pressure was applied to his neck, which is strangulation, but there's also a different form of strangulation as well, or not strangulation, but asphyxia, which is positional asphyxia, which is when there's pressure being applied to the chest or to the back that doesn't allow the lungs to completely expand. So there are multiple things that were going on at the same time, but as Dr. Datta mentioned before, it has to be continuous pressure. So there are certain times where the pressure was released and you saw that he was able to talk. There were times when he was moving around. So it wasn't continuously, the pressure wasn't applied continuously for 8 minutes. But based on the video clips and even the transcripts from the ER doctor who actually testified on his case, you saw that even after he lost consciousness, which means that there was at least 7 seconds of pressure applied to his neck, he lost consciousness. But even a minute after losing consciousness, a minute after EMS arrived, pressure was still being applied. So if at any point pressure was released, he probably could have survived. And some of the reactions that you also saw in the video, as Dr. Datta mentioned, from the agitation, the confusion, this is somebody who has hypoxic brain injury at this point, and is also has the thought that they may potentially be dying, and they felt themselves dying, and they actually died. So, so don't be surprised by the 8 minutes and 46 seconds, because this wasn't continuous pressure that was applied during that time.
So then these are the common symptoms that some patients experience after they have non-fatal strangulation. There's 3 things I want to talk about: is ptosis, the facial palsy, and left or right-sided weakness. What would that be concerning for you guys if a patient came in with that? What would you guys be worried about? Stroke, right? Exactly. So it just talks about the significance of how bad this damage can be on a patient's brain. Another thing that it can cause is delayed strokes or encephalopathy as well. There have been studies that have shown that patients that have strangulation, long-term wise, a common complication is they have encephalopathy. There's also risk for dissection. So when someone is being strangled, the victim may try to remove the chokehold by trying to move their neck, trying to grab the person's hand off of them, and that can cause a little bit of dissection within the artery itself. That dissection can grow over time and put someone at risk for a stroke. So one of the things that we have to do, and this is why we implemented our protocol, is if we see anything that's concerning, we want to make sure we do a CTA immediately, because if we see a dissection, it could be very, very important in saving this patient's life. We actually trained law enforcement, and there was this one officer that after this lecture, he had a patient that unfortunately was non-fatal strangulation. The patient was complaining of difficulty breathing. He really urged the patient to go to the hospital. When they did go to the hospital, the ER doc was like, "Oh, there's no external signs of trauma. You're breathing fine. Your vitals are fine. Discharge." And the officer was like, there could be a risk of, and, had a conversation about like 50% people have injuries. There could be a risk of strokes, dissections, whatever. Somehow this officer convinced the EM doc to do the CTA, and she had bilateral dissections and she was admitted. So it's rare, but it's still possible that it's going to happen, right? If we have a patient that's a trauma, if we have a patient that fell a couple of feet or that was riding a bike and had LOC and they come to CCT, what would we do? We would probably do a CT head to clear them, right? If there's LOC, we should have the same type of workup and management for our patients with non-fatal strangulation as well, especially if the patient is saying, "I don't really remember." That's a sign of decreased oxygenation, or "I kind of blacked out," or "things were kind of fuzzy." Those are all concerning signs where you should really consider doing images for these patients. In the 1980s, they saw a bunch of young women with no medical histories, no risk factors coming in with strokes and severe complications. When they did a look back on their history when it came to domestic violence, a majority of them were strangled by their partners in the past. So there's a correlation of cervical artery dissection because of strangulation long-term. And one of the ways that we can prevent this is we can connect them with the TBI clinic, which we are doing right now. We are referring our patients to that. They'll be able to get followed by neurology. And if they think the patient needs to be on aspirin for prophylaxis, they'll be able to start that as well. Strangulation is rarely in isolations. There's other forms of trauma they can experience, whether it's sexual assault, whether it's blunt trauma. So it's always important to do a full head to toe exam on these patients as well. Make sure you take off their clothes and do a thorough exam. Anything that you see, any petechiae, any bruises, any scratches, excoriations, it's important to have the nurses take a picture of it because that's a documentation that's going to help with getting the case prosecuted. Unfortunately, we are working with the judges and DAs to have them know the importance and the significance of non-fatal strangulation. But right now in the court system, not a lot of people think it's that as serious of an injury. So a lot of these perps are actually walking away free. And when they walk away free, they can possibly go back to the victim and finish the job or continue to terrorize them. So like we said, this is the underdog of intimate partner violence because these patients typically don't have external signs of injury. And there's always a lot of shame for these victims as well. They feel this sense of shame that they're in this situation. They feel embarrassed. They may not think it's necessary to seek medical care at this time. Their ultimate goal is just to be physically safe and get themselves away from the abuser. So it's important for us to know when they do come to the ER that we take their complaint seriously as well. We're going to play another video for you guys to hear.
San Diego Police, Martinez.
Yes, right now, please, please officer, assistance right now, please.
Where?
That's 15K, it's right by Riptide Brewery.
Now, what's the problem?
I was adopted by my boyfriend, and he's telling me the fuck out of his house, and I live there, and he's pushing me around and everything, and I'm pregnant, and he doesn't understand. I was in the hospital yesterday, and right now he's at work, and I'm bleeding.
Do you need an ambulance?
No, I like a police officer right now because he's on my ID.
Okay, well, just a second. Calm down. You said you were bleeding. Why are you bleeding?
My hand's bleeding.
Your hands?
Yeah.
From what?
I don't know.
Also, do you need a paramedic for your hands?
No, my hand's okay. It's just breaking. But right now he's in the restaurant. He won't give me none of my stuff. He tackled me down. He tried to choke me.
Just now?
Yes, right now.
Okay, and where is he at?
He's inside this building right now.
At 5th and K?
Yes, the Riptide Brewery.
What's the name of the place?
Riptide Brewery. RJ's Riptide.
Okay, you're going to have to calm down because I cannot understand you. You're at where?
I took an asthma attack.
You're what?
I had asthma real bad.
Do you want a paramedic for your asthma?
If it's possible to pick me up, please.
Okay, hold on.
Right now he's leaving the building.
Okay.
Medical emergency for you.
Said she's having an asthma attack.
Okay, ma'am, are you at the gas lamp merchants?
Yes, I'm at RJ's Riptide Brewery. I need a police assistance right now, and I don't care. This guy choked me.
Okay, ma'am, wait a minute. You said someone's choking you?
No, it's say we're having a DV, but she's having an asthma attack talking to us.
What's a DV?
A domestic violence. He pushed her.
Ma'am?
Yeah.
Okay, where's the person that pushed you?
So several things went wrong. I see some people shaking their head. Can someone tell me what were concerning things that went wrong in that call? And we'll pick on people.
Or first, what went right? One thing that went right, maybe, or two things.
Okay, so how about when they called the paramedic and the paramedic said, wait, you were choking and you're short of breath? Was that a good thing that he asked? Was it a bad thing? It was a good thing, right? And the response that they got was, no, it's DV and she just has an asthma attack. So once again, that's not making much sense. Another thing is them telling the patient to calm down. Once again, she cannot breathe. She's terrified for her life. Telling someone to calm down, telling me to calm down when I'm upset is not going to help. Telling someone that cannot breathe to calm down is not going to help. And there was also a minimizing of her symptoms, right? She's saying she was choked. She's saying she can't breathe. And this dispatch automatically assumed asthma attack. But the patient said, I don't know if you heard it, I don't have a history of asthma, so I don't know why I can't breathe. So these are all really, really important things to know. Thankfully, the paramedic was intuitive and said, okay, something is off. She's saying she's choking and you can't breathe. We have to make sure that we get medical. and they were getting medical attention for this patient, but on the first call, the patient said, I don't think I need medical. I just need a law enforcement to come here right now to protect me. And she also said the same thing. I don't think I need a doctor. I just need to get out of here.
Right. So just as you heard in that clip, most of the victims will be frantic. They, because at that moment, they feel like they're about to die. There are several different studies and the data varies a lot, but almost 99% of people who are being strangled believe they are going to die. Strangulation has been associated, or at least been seen as being equivalent to waterboarding. It's usually a form of asserting dominance and authority, creating intense fear in the people who are being strangled, and leaves very few marks. It can result in loss of consciousness, like Dr. Datta mentioned before, and even death. And it can be used repetitively and easily because the hands are just readily available. Unfortunately, it's being minimized. It's being minimized by the dispatchers, like you mentioned, like you heard in that audio clip. It's being minimized by police officers when they show up in the scene. It's being minimized by EMS. This particular paramedic, it seemed like when he heard choking, something lit up in his head because he knows choking is a very significant form of intimate partner violence. But it's also being minimized by medical providers because sometimes we don't understand why these patients are coming in altered, confused, they seem intoxicated. You know, even though they say they didn't have anything to drink or they didn't consume any form of substance. And, you know, and a lot of times we won't hesitate to do a CTA scan on somebody who went to a chiropractor is complaining of neck pain and we're concerned for a dissection, but however, we don't do the same thing for somebody who complains of possible strangulation. The victims themselves, they minimize it. Like Dr. Datta mentioned, they'll come in and they'll say, like, you know, they want NYPD, they want law enforcement because they're scared for their lives. And a lot of times when EMS shows up on the scene, they refuse to go be transported to the ER. And when they transported to the ER, sometimes they don't get the imaging that they actually need. And this continues. When the case goes to court, the prosecutors minimize it because they don't understand the medical components and the complications that could occur with strangulation. The jurors, they don't understand it. These are just regular day-to-day folks who have no medical knowledge. They don't understand why somebody could be strangled but not die. I thought strangulation, you won't get strangled to death. How do you live after you've been strangled? Or how if they had all these injuries, wasn't it documented by a doctor? Didn't they go to the hospital if they were scared? Why didn't the doctor who saw them document it? And a lot of times a case can be dismissed by judges who don't understand what petechiae is. They're like, what are these little red dots that you're talking about? And why do some people have it and why do some people do not have it? So the challenge is like, how do you know the victim was strangled or suffocated if most victims have no visible injuries? And how do you know if the blood flow or the airflow was impeded if no one asked the right questions, which means us, if we don't ask the right questions, because the patients do not come in saying, oh, I'm coming, my chief complaint is strangulation. They don't. Almost rarely not. That's rarely the case. And how do judges know they have a serious strangulation case in their courtroom if no one, and by no one, I mean no medical provider has documented the evidence in the medical charts. And by documenting the medical charts doesn't mean that you're going to be subpoenaed. Actually, you're going to be subpoenaed if nothing is documented. Let's say somebody comes in with strangulation and goes to court, but there's no documentation of that injury. Then they're going to call you in and ask you, well, did you see the patient? Were you concerned? Were you not concerned? Why didn't you document this? And that's what's going to happen. But if you do document everything, the chance of you getting subpoenaed is actually slim to none because they have everything that they need to figure out what they're going to do with the case. We're not here to decide whether or not somebody gets convicted or doesn't get convicted, but we're here to just do our jobs and document things. Sort of like Dr. Park was mentioned, even with like decubitus eye ulcers. So this was created by the Training Institute for Strangulation Prevention. These are signs and symptoms of strangulation, questions that you can ask your patients when it comes to your history and things that you can look for when it comes to your exams. But even if you don't see any sort of visible signs of injury, like Dr. Datta mentioned, 50% of injuries are not visible. Okay, so or 50% of cases of strangulations, victims will come in with no forms of visible injuries that you can actually see. But like I mentioned before, with the case that I saw with the ME's office, well, that was one of many cases I saw in the ME's office, you can actually see hemorrhaging underneath the skin that may not be visible on exam. And then Dr. Datta mentioned this before, you have to think about the color, the skin color of a patient, somebody with darker complexion, you might not see the erythema that you're typically expecting to see when it comes to ligature marks or fingerprint marks when it comes to strangulation. But it might show up like a little bit darker or like purple in color. So if you do see something, you're not sure if it's a sign of strangulation or if it's something that's normal for the patient, just ask them, was this here before? Do you remember this being here before? And, just involve the patient as part of a part of the exam as well. Dr. Datta mentioned about petechiae, very similar in this picture. You can, if you're not sure if this is petechiae around the eyes, you can ask the patient, well, was this here before? Do you usually have freckles? Or, and if it's completely new, then document it. Have the nurses take photo documentation and upload it to Epic. But what we never want to do is take photo documentation of genitalia into Epic. But anything outside of that, that's fine. So there's more pictures of petechiae here around the eyes. Pull down the eyelids, you can see more here, and you can see subconjunctival hemorrhage as well. Look inside the lips, you can see sort of like signs of blunt trauma inside of the lips from like possibly being punched or pushed to the ground and things like that. And then here, if you look at this particular patient who came in, you'll see like these, what most people say is like fingerprint marks on the neck. But a lot of times what you can see is actually the fingers will actually be in the space where you don't see any erythema, because usually the pressure that's applied to the neck sometimes can push the blood vessels to the side and cause injury adjacent to the area where the pressure was actually applied. And then here you see actual fingertips on the lower image. This is a picture here showing what I was mentioning before, which can be easily mistaken for a battle sign, where you see like erythema, ecchymosis behind the ears. This can be from the sternocleidomastoid. Good question. It is. That's a great question. So if a patient comes in, because we're seeing there's a lot of cases of sexual assault and strangulation being used in sexual assault. And in those particular cases where you do have, when you're activating SART and they're getting forensic evidence collection or forensic exam, this is part of the forensic exam. So the sexual assault forensic examiner will do all of this. They will take the pictures, they will document it in their records and their chart. But unfortunately, not all patients, well, it's not fortunate, but some of the patients are not, they're being strangled without sexual assault. So these are the cases where we might be the ones who are seeing them. So I would recommend that you do have the nurses documented in the chart and document as well in your own words. Just describe whatever you're seeing. And then you see defense or scratch marks at times when Dr. Datta mentioned the individual might be trying to pull the person's hands away from their neck, and they may accidentally scratch themselves as well in the process. You're seeing more here, more struggle signs, another sign of sternocleidomastoid tearing behind the neck. And it's important that we have the nurses document, because this is a patient who came into the ED. This was the picture that was taken, and this is a couple of days later. Okay, so what you're seeing right now might not be there a few days later. So it's important that we document in the chart whatever we are seeing. Dr. Datta mentioned earlier, when it comes to strangulation, around 14 seconds, you can have anoxic seizures. And at 15 seconds, you can have loss of bladder control. When we have somebody who has a history of seizure who comes to the ED, and what do we ask? We ask about urinary incontinence, right? And they might be confused. They might not be able to tell you they had a seizure, but once they mention, you ask, did you have urinary incontinence? They're like, oh, I'm not sure. They look down like, oh, I guess I did. Then you're like, okay, this person has a history of seizures, urinary incontinence, they had a seizure, and they're confused right now. So this is something that is important to ask your patients as well who are coming with strangulation or LOC, whether or not they had urinary incontinence, and whether or not they were aware of it. Because sometimes it could be a response to fear, right? Someone could urinate on themselves, but they know that they urinate on themselves. But in the case of a patient who has no recollection, they're like, I don't remember, I didn't notice it, it's good to ask. And sometimes they may even change their clothes before they come into the ED. And then we place this picture here just to remind everyone that patients who are pregnant are at increased risk of intimate partner violence and domestic violence altogether. So just keep that in mind, especially with pregnancies. And this picture here is just to represent 50% of those cases where there is no visible injury. This is somebody who was strangled. If pressure was applied to the neck that may have closed the airway or the blood vessels, strangulation occurred. It doesn't require death. It does not require visible signs of injury. ASAP has already recognized this. They have recognized the increased morbidity and mortality associated with strangulation and neck compression. So it's important that we do evaluate these patients when they come into the ED. One of the big issues that we're having right now is because there is data out there that can be a little bit conflicting. A lot of people will use this particular study, I believe by Jacobson, where they looked at CTA scans that were done for individuals who had blunt traumas to the neck. And they saw that only 1% to 2% of individuals actually had blunt cerebrovascular injuries, which is like carotid vertebral dissections. When I look at this number, they're like, this is very minimal, this is not a big deal. But if you're seeing 100 patients a week, let's say you saw 100 strangulation patients a week, that's about 1 to 2 young patients who are walking out your ED, who may have a dissection and who may show up back in the ED or another ED with a stroke in a couple of days to months or even years from the strangulation. So and it's something very simple, because if we detect it on CTA and it's a very small dissection, they could easily go home with aspirin, but if we miss it, it could be very detrimental to them. So I think 1 to 2% is a big deal to me, but that's a study that most people use when they're like, okay, I don't want to do a CTA. But then you have this other study here that was done by this level 1 trauma center. And they looked at the scans that were being done by using different tools like the Denver screening tool for blunt trauma to the neck. And when they saw that, when they actually used that particular tool to screen whether or not somebody should get an actual CAT scan or CTA, they only scanned about 1.5% of their patients. When they scanned 1.5% of the patients, they didn't see, they saw like maybe about the 1 to 2% of carotid vertebral dissections. But when they implemented this study, they decided to scan more people. They looked at not only individuals who had visible injuries, but individuals who had certain symptoms, different signs, like they're complaining of shortness of breath, whether it be before they came into the ED, or they're complaining of dizziness, loss of consciousness, or just neck pain that might not actually be turnus on exam. When they did that, and they include these individuals into that study, and they actually scanned those individuals, they scanned from 1.5%, they went from 1.5% being scanned to 90% being scanned. So they almost times it by 10, basically tenfold. And they saw that they found 37% of dissections. So these are dissections that would have been missed if they hadn't expanded their study, and they hadn't expanded, basically scanning more people than was considered to be the standard. So just to show you guys the protocol that we created here at Kings County. This protocol, if you look on Clinical Monster, you'll find it. It basically shows the different signs and symptoms you can look for. If the patients coming in, they have any of these signs and symptoms, then we do recommend that you do a head CT if you're concerned for TBI. And obviously the most important thing is a CTA if you're concerned for strangulation and for carotid dissection. If these patients are stable, then obviously they can be discharged, but we want them to follow up with the TBI clinic. But before they're discharged, we want them to be seen by social work, of course, and given additional resources as well when it comes to where they can follow up for social services. And very quickly, I'll just mention, since we're running out of time, this is a particular study that was done, I want to say it was in New Zealand. But don't quote me on that. But this is an 80-year-old male. He came into the ED complaining of basically being strangled by his younger, I think it was like a 55-year-old wife or 65-year-old wife. She strangled him. He was having difficulties talking, change in voice. He came to the ED and they saw him. And initially, they didn't really see much erythema around his neck. There wasn't any signs of strangulation, according to the provider I saw him. But because he was having difficulty speaking, they did have ENT see him. ENT scoped him. They're like, the airway's not compromised. He looks good to us. He was getting ready to be discharged. Of course, it took a little bit longer than expected for him to be discharged. He was hanging around the ED for a little while. Next thing you know, he coded. He coded and he died in the ED. He had an autopsy done. When they did the autopsy, they noticed that he didn't have much erythema on the neck either, like the providers had mentioned on the medical exam. But this particular ME's office had the ability to do a CAT scan. So they did a CAT scan and they saw that he had a large hematoma that was actually underneath the tongue. And that was what basically caused his death. So he had expanding hematoma that eventually impeded on his airway. It wasn't impinging on the airway at the time when ENT saw him, but it continued to grow while he was in the ED and he died there. And then when they did the autopsy, this is what they saw underneath the skin. So the medical providers didn't see much. There wasn't much there to be seen. But then once they did the autopsy, they saw all the hemorrhaging that was happening underneath the skin. So just know that just because you can't see it doesn't mean that there's nothing there. If somebody comes in complaining about strangulation, just remember the definition of strangulation: pressure on the neck that may cause closure of the airway or the vessels. And if their airway is being closed, they might not be able to speak. But if it's only the vessels but not the airway, then they'll be able to speak. It's just that they might feel confused and might actually lose consciousness while still being able to speak. And if you just look at this, you could grab it from either myself or Dr. Datta's list of smart phrases. We have a smart phrase, KC-ED strangulation. And you can basically get discharge instructions that you could provide for patients in the case that they are stable enough to be discharged after their CAT scan, just to look for different forms of injuries that may evolve after they get discharged. And that's basically it.
Any questions?
I know we went a little bit over, sorry.
Perfect.
All right.